Co-Prescribing Benzodiazepines and Opioids, the black box of increased overdose risk. I am Morgan Gargiulo, Senior Communications Specialist for Qualidigm, and I will be facilitating today's webinar. Wow, I can't talk today. Next slide, please. So for those of you who don't know, I wanted to give a little bit of background about Qualidigm. In January of this year, Maine Quality Counts merged with Qualidigm, and we are a mission-driven national healthcare consulting organization with multiple offices across New England. We have over 35 years of experience in improving healthcare delivery. We specialize in quality improvement, project management, and technical assistance. We have been a leading federal quality improvement contractor since 1983 and the Northern New England Practice Transformation Network since 2015. Next slide. So today I just wanted to go over a few items about the CMEs. Today's speaker does not have any relevant financial relationships or manufacturers of any commercial products and or providers of commercial services discussed in this CME activity. So basically we're good to go today. CMEs will be available for participants who have signed into the live webinar. If there are multiple people at one computer, please make sure to type their names and email addresses into the chat box for our attendance records so that we can make sure you get the link to the evaluation following today's webinar. We do not have separate nursing CEUs, but you can still get a CME certificate if you desire. Once the webinar has ended by us, the host, you will get a pop-up on your screen that immediately directs you to the survey. If you happen to leave the meeting before we close it, that link will not automatically pop up. So please make sure to wait until we close the meeting to complete the evaluation. The survey will be open for 2 weeks following this webinar. Again, you will be able to immediately download your CME on the last page of the evaluation. And if for any reason you have any problems, questions, concerns, you can contact Lise, and her email address is on the screen. And we will also provide that in the follow-up email that we send about today's webinar. So next slide. I wanted to go over just a few notes. Everyone is in listen-only mode. So please use the Q&A function to ask questions or make comments. We will review all of the questions at the end of the presentation today. If you haven't used Zoom before, the video screen and box locations are totally customizable, so you can click them and drag them around according to your preferences. And again, I'm just going to plug it one more time. If you're joining by phone or with others on this computer, please make sure that we get your name and email address. And again, Lisa's information is on the screen again. So next slide. Funding for this webinar is through a contract from the Maine Department of Health and Human Services. Next webinar. And finally, I wanted to introduce today's speaker. Dr. Mock is a family physician living in Holden, Maine. She's spent 2 years at Colby College before going away from Maine to finish college at Emory University Medical School at Vanderbilt University and a Master's of Public Health at UConn Chapel Hill. She has developed opioid education curriculum for the Maine State Academic Detailing Program, MICIS, and has given enthusiastic presentations all over Maine since 2012. She is board certified in both family medicine and addiction medicine. Her part-time clinical work includes evening shifts as a hospitalist and prescribing at, oh, I'm gonna butcher that, Dr. Mock. You can clarify that when you hop on. She's passionate about women's and girls basketball, travel, chess, singing, and weight training. So with that, I will pass it over to Dr. Mock to get us started.
Thank you very much. So it's easy to pronounce, just say bupe, and then you'll sound like you're in the know for buprenorphine. Everyone, today for this presentation, which is a joint venture between Qualidigm and the MICIS program. MICIS is the Maine Independent Clinical Information Service, and we are a program of the Maine Medical Association. And as you have heard, we receive our funding from the Maine DHHS. And I'm learning how to use a new computer. Do I have to use the mouse? Okay, the arrow buttons aren't working, so I'll use the mouse. Is this, okay, nope. We're on board. So we don't accept any pharmaceutical monies, no significant relationship. I will point out if we talk about anything that's an off-label use of medication, and it says prizes provided by private donation. Unfortunately, all of you are online today, so there's no prizes. But when I did this live for the Maine Osteopathic Association, we had really awesome prizes, including little lobster napkins and lobster paper plates and everything lobster, because it kind of went along with the theme. But I bought all of those myself at Christmas tree, and it was separate. So today we're going to talk a little bit about benzodiazepines and the intersection between benzodiazepines and opioids, talk a little bit about tapering, always talk about risk reduction and harm reduction because that's what we do. And I really wanted to do a couple of acknowledgements right at the beginning to talk about the Bangor Area Controlled Substance Work Group, which is a collaborative group of clinicians in the Bangor area. All of the major health systems are involved, including the Northern Light Eastern Maine system, the St. Joseph's system, PCHC, Penobscot Community Health, and multiple other area practices. And we have been meeting together as clinicians, at first monthly and now quarterly, for several years now. And we came up with a lot of sets of standards for all of the area practices, including informed consent and some practice and prescribing guidelines. And it's just been a really amazing think tank and really instrumental in me, to me as my development in addiction medicine, as I am somewhat late to the addiction medicine specialty. Specifically Trip Gardner, who was the previous chief psychiatric officer at PCHC and has now retired, and now Vijay Amarendan, who is also now a psychiatrist at PCHC, because they have done several webinars over the past few years about benzodiazepines and started putting together a lot of this content before me. So we're gonna have some materials today and I'll have some screenshots of them. We will include them with the links from the presentation in terms of the paper handouts, and I have a couple of live copies here to show you. And they're also on our MICIS website, so they can be downloaded and shared and used with patients. So I'll take that just for a second to pause and put here I have an advertisement for anyone who needs their 3 hours of CME for opioids. We have tonight in Auburn, tomorrow night in Brewer, and Thursday night in Belfast. It's sort of the last push of the 3-hour conferences for MICIS for the year. So if you want to come and talk to us, and then this is the last hour, so then you could just leave the last hour and you'd have your 3 hours, 1 now, 2 then. So we have that going on for MICIS. So here's one of the first patient handouts, and I'll show a demonstration here. I found this from another organization that was really gracious in terms of allowing us to resize their document and then make copies with proper attribution to distribute to our providers around the state of Maine. And it looks great on a color printout. It's really helpful, and it talks about some really simple things in different categories in terms of things you can do, things you can think about, and then things you can do to keep your body healthy in terms of dealing with stress and anxiety. And when we're talking about benzodiazepines, the #1 indication that people use to prescribe benzodiazepines is anxiety. So to think about some non-pharmacologic treatments and to go back to the basics. And this is good for all of us all the time. I sent a copy of this to a friend of mine earlier today who is at her a malpractice panel review. Talk about stress, right? And so I sent her a copy of this on a photo just to remember some of those basics that we think about under really high stress, high anxiety situations. So that is one of the handouts that we have that's available. The next handout is from our friends Choosing Wisely, with which Qualidigm and the agency formerly known as Maine Quality Counts is well familiar, doing lots of work with Choosing Wisely. And this is specifically for patients over the age of 65 who have insomnia or anxiety and are prescribed benzodiazepines and other drugs to treat those conditions. It's specifically written for patients, and it talks about why these medications might not be safe. And me personally, every time I admit a patient to the hospital over the age of 65 who is on one of these drugs chronically, I will go in the emergency department and print it out. It doesn't come out in color, but it comes off the printer in the emergency department. I bring it back in and I leave it with the patient and I talk to them about this medicine that you've been taking for a while. It turns out that as you get older, it's very, very risky. And these are some of the risks to you. And so I'd like you to read this while you're here in the hospital for some other reason. And I'd like you to talk to your prescriber, your primary care provider, after you get out of the hospital about, is it time for me to reduce the dose of this medication and to think about an alternative? So I like to plant that seed every time I see a patient, even if it's the only time I'm seeing that patient. I'm going to be doing this backwards all day. So I think it's kind of dry to be online in a webinar, hearing lots of data about prescribing benzodiazepines. And so I had to make a game out of it. And so for you to follow along at home, you might want to get a piece of paper and make yourself a little score sheet. Or if you're a millennial, then you would take your phone and open up your calculator. And you want to keep track of how much money you're winning in your Jeopardy game. Here's the rules. So if we were in a room, we would do 3 people per team, but we're not in a room. You cannot look it up on your smart device. It's too fast. You won't have time for that. If you get the question correct, you will earn that money. You have to keep track of your own total. But different than regular Jeopardy, there's no points off for incorrect guesses. So in regular Jeopardy, if you guess wrong, you lose that money, right? But in medicine, it's more important that we commit to an answer, even if we're wrong, than to not commit to any answer at all. So no points off for incorrect guesses. So here we go. There are a lot of really effective good things about benzodiazepines. They are very effective in terms of controlling anxiety, particularly in the short term. They're effective and used widely in anesthesia. They're very effective in terms of working with seizures as an anticonvulsive. One of the best times I have presented this talk was to a group at MMP Neurology last month. And it was just really fascinating to talk to them because they prescribe benzodiazepines very frequently. And we had a great interaction in terms of talking about the role of these medications and maybe how their prescription has evolved, which we'll talk about. Also can be effective as a muscle relaxant, but there are a lot other safer alternatives. So here's the first question for $100, benzos. You can write down a question if you want, but no one's watching you because you're alone on a webinar. What is the most frequently prescribed benzodiazepine nationally? So this is national numbers. What is most frequently prescribed? I'll give you 10 seconds to write down the answer. Okay, that's long enough. So here's the list. Don't get too excited yet. Here's a list of commonly prescribed benzodiazepines in alphabetical order. So number 1, alprazolam, clonazepam, diazepam, all the PAMs, lorazepam, tomazepam, and then there's their brand names on the side. Remember, in academic detailing, we always talk in generics, but we also know that people remember brand names better sometimes. Interestingly, alprazolam is one of the top 3 diverted prescription drugs. So not a great player in the scene of problematic prescribing. So, and here's your answer. This is from 2011, the most recent data I could find, but alprazolam is number 1, almost 2 to 1 over the next 2 competitors, who are lorazepam and clonazepam. So alprazolam by far the most popular benzodiazepine in the United States. Okay, so here we go, 200. So you know that by the end of the class, we're gonna be at 1,000, right? So here are 200. You can do any of the 3 generic names for a Z drug or a sedative-hypnotic. You got to come up with one of the 3 generic names. There's one that we use the most that's probably the easiest to come up with. I'm going to do 5 seconds for answers. So we want to think that Z drugs are very similar to benzodiazepines in terms of their risks and the way that they work on respiratory depression. So we want to kind of, I think of them as almost the same type of, same class of medication in my mind. So here we go. Here are the Z drugs. Probably the most common one that we'll see here in Maine in terms of market share is zolpidem, otherwise known as Ambien. And then Zapolon and Zopiclone are the other 2 that we don't see quite as commonly. So interestingly, in the laboratory, when they're doing studies, they can look at zolpidem impairment, and they have determined that a blood level over 50 is sufficient to increase your risk of motor vehicle crash. So I call that legally drunk, right? If this drug level in your blood increases your risk of a motor vehicle crash, that's kind of like a blood alcohol of 0.08. Interestingly, benzodiazepines and alcohol, very similar because they all work in the GABA area, which I don't have any slides of receptors. But the point being that when we take zolpidem, 8 hours after immediate release zolpidem, 15% of women still have a blood level above 50, but then look at the extended release. So extended release zolpidem, otherwise known brand name as Ambien CR, 33% of women and 25% of men, 8 hours later, still have blood levels above 50. So technically, they're still what we're going to call legally drunk 8 hours after taking this medication, impaired sufficiently to increase their likelihood of having a motor vehicle crash. So these medications last for a long time and their impairment frequently isn't recognized by those who are taking them. So let's talk a little bit about benzodiazepine trends. So we're going to focus a little bit on benzodiazepines, and then we're going to work in some of the opioid stuff. But there's a lot of parallels. So we know that limited dose and duration benzodiazepines are safe for many or most patients, and that they do have a role in some situations in terms of short-term use, lowest possible doses. The problem is over the past 20 years, not only have we been prescribing more opioids, we've also been prescribing more benzodiazepines, and we see so many patients now who are taking much higher levels of medications that we're not perceiving the risk as it is. Even 5 years ago, maybe we weren't thinking about the actual risks of prescribing opioids to a large number of patients until some of those numbers started coming out in terms of the number needed to treat and the number needed to kill in terms of chronic opioid prescribing. So this just came up, and I'm going to say no, that I don't want to synchronize right now. Yeah, no. The computer wanted to update, of course, right in the middle of a webinar. So 300. Here's the marketing nickname for diazepam, Valium, when it was introduced in 1963, and actually the Rolling Stones wrote a song and mentioned this. So if you remember your old marketing slogans, here's the name. I should put this for 1,000 because this is a good question. But so we know that pharmaceutical marketing is often said to be the key cause of the opioid crisis, because we know that there are several pharmaceutical companies that were really urging us and urging JCO to help us to increase opioid prescribing. Interestingly, in that same time frame, benzodiazepines, which are largely generic, no one was marketing them to us. And yet in the same time frame, if you look at the curves, see if I'm doing that in the right trajectory. But anyways, that they're pretty parallel in terms of the increases in prescribing. So now we're up to 400. This demographic group are prescribed benzodiazepines at twice the rate of their counterparts. So when you're thinking about demographic information, this used to be a binary demographic group. You were either A or B, but nowadays, in our more modern thinking, we're thinking that maybe there's more than just A or B, but focus on the A or B. So if you are A, you're twice as likely to be prescribed a benzodiazepine than if you are B. Might not be worded the best because I don't have a staff of Jeopardy people helping me out here. So it turns out female, right? So we traditionally have thought of gender as binary, female or male. Now that is evolving. But if I'm a female, I'm twice as likely to be prescribed a benzodiazepine than a male. And there are a lot of things behind that, which we won't go into. The other thing is if you're an older age. So when we look at long-term prescribing of benzodiazepines, over the age of 65 is twice as likely to be prescribed a benzodiazepine than a younger person in the 18 to 35-year-old range. So in the same time frame as the opioid crisis, which was largely thought to have started in 1999 and gone up now for 20 years, in that same time frame, we've seen a 67% increase in the number of adults who filled benzodiazepine prescriptions. So more and more adults are being prescribed benzodiazepines in the same time period. And more concerning to me is in that same time frame, the amount per prescription has tripled. So we're giving more and more adults 3 times as much drug. Here we are up to 500, so we're doing great, right? I'm keeping an eye on the clock here. This class of psychiatric drug was the most prescribed class. It contained the most prescribed drug in 2016, and I gave you a clue. It's not a benzodiazepine, which makes me very happy. So this class of psychiatric drugs contained the most prescribed psychiatric drug in 2016, and it should, because it's indicated, it's safe, and it's effective for the psychiatric conditions for which it's prescribed. So what class of drugs is the best one to prescribe? So there you go, sertraline, which comes under the class of, if I had a group, everyone would say SSRIs. So SSRIs, #1 prescribed drug in 2016 in terms of psychiatric drugs. So, and that's appropriate, it really should be. When we look at some of our handouts, we're gonna see that SSRIs are really first line for many anxiety-related and depression-related diagnoses. Sadly, our friend alprazolam, that we know is the #1 prescribed benzodiazepine and one of the top 3 diverted drugs according to the DEA, was #2. So we can see, and lorazepam was also in the top 10. So we know that benzodiazepines have a lot of risks. So there's a significantly increased risk of overdose when prescribed with opioids. We'll talk about that. Markedly increased risk of falls, especially in our older patients. Cognitive dysfunction, the pseudo-dementia, that people are really foggy. And then just over time that they become less and less effective for whatever it was they were prescribed in the first place. And then a lot of other sideline respiratory risks. One of the studies that I looked at was very interesting because they said that there's a possible increased risk of cancer, but there's an association of taking benzodiazepines and smoking cigarettes that they haven't been able to tease out in the studies. So that could be a confounder. It may just be that people who take benzodiazepines are more likely to smoke, therefore they have a higher risk of cancer. They haven't been able to tease that out, but they've seen that possibility and they raise that, and other respiratory problems related to benzos increase risk of worse outcomes with those diseases. The other thing that we know is in, I think Trip Gardner put it in his slide deck that I reviewed over the weekend, addiction is addiction is addiction. So the pathways that cause people to have use disorders related to substances are similar for all substances. So if you have another substance use disorder, your risk of developing a benzodiazepine or sedative-hypnotic use disorder is 12 times the general population. So if you've had problems with one controlled substance, including alcohol, your risk of having problems with a different controlled substance is markedly higher. So these people are at much higher risks when they take these medications. So let's talk a little bit about alternatives, right? Because it's easy enough to just say, we've started prescribing more, don't prescribe so much. Okay, well, what are we gonna do instead? What do we know that the evidence says that tells us to help us to treat our patients with anxiety, to treat our patients with insomnia? So here's next question, $600. This specific type of psychotherapy is recommended as a first-line treatment even before any pharmacy is used for multiple anxiety and other diagnoses. So this is a specific type of psychotherapy. You can put the full name or you can put the initial acronym for it. I don't think my slide actually says it, but the answer is CBT, Cognitive Behavioral Therapy, not to be confused at all with CBD, which we don't have any good evidence that actually helps in anxiety. So CBT, Cognitive Behavioral Therapy, we know that multiple types of psychotherapy, but the most widely studied cognitive behavioral therapy have been shown to be very effective in terms of anxiety. And also with insomnia. The difficulty is sometimes finding people who are trained specifically for insomnia-related CBT. So then we have the handout here, which, like I said, will be in the links and is on our website. So it talks about different things to think about when we're looking at a diagnosis of anxiety, including non-pharmacologic treatments. And then it talks about some recommendations for evidence-based medication treatments. So as you can see, SSRI for multiple anxiety-related diagnoses and PTSD is considered the first-line treatment and an evidence-based treatment for these diagnoses. And then it goes into SNRIs and TCAs, and there's kind of this whole list here. On the back side of this handout, from multiple sources, it also goes through doses of different drugs, and then it also talks about some of the supplemental drugs or herbal medications. What do we know that the evidence says about them, and what have some of the, what tend to be limited studies shown about them. And here's just sort of a blow up of medications that we would use for anxiety and PTSD. Interestingly, benzodiazepines are thought in PTSD to actually worsen outcomes with that disease. although you would think, oh, well, they're hypervigilant and they need to be calmed down, that sometimes benzodiazepines can be harmful for patients with PTSD and they are not recommended. And then you can see some of the different medications that are recommended based on evidence as more effective treatments. So first, I'm gonna talk about a couple of bigger studies. The first one is specifically about benzodiazepines, and then we'll talk a little bit later on about one that was about benzodiazepines and opioids. So this is a little bbit of data, and then we'll get into this one big study. So, oh, here we are, we're into the study. So the Boston Community Study was done, I think, through Partners Health, but I'm not sure. So they had 66,000 patients in a capitated system. So they were able to query the EMR and look at these patients, and they saw that 15% of their patients had been prescribed a benzodiazepine during the study period. A little bit less than half from PCPs, a little bit more than half from specialists. We have to remember this is in Boston, so likely in the state of Maine, we would not see these numbers. We would see 80 to 90% from PCPs and 10 to 20% from specialists, most likely. We would see a different penetrance of specialty prescribing. So this was published in 2016. What they found was the patients who were prescribed benzodiazepines had more PCP visits, more specialist visits, more emergency department visits, more hospitalizations, and a longer length of stay. And the p-value for all of them was less than 0.01. The difficulty with this is it may be a little bit of a chicken and egg type of story. So the patients with high levels of comorbidity may be more likely to be prescribed a benzodiazepine, and the patients prescribed a benzodiazepine may be more likely to have multiple chronic diseases and be sort of medically fragile. So both may be correct, but there's a very strong association between the patients who are at most high risk for adverse outcomes from this drug and being prescribed this drug. And so let's look at a couple of those. So the odds ratio of being prescribed a benzodiazepine, all of these patients with these diagnoses were more likely than someone who didn't have this diagnosis to be prescribed a benzodiazepine. So depression, substance use, and we talked about addiction is addiction, tobacco use, and then other things that could be worsened, like osteoporosis. So if you're much more likely to fall and you have osteoporosis, you're sort of like increasing that risk by a lot. COPD, respiratory depression, asthma, obstructive sleep apnea, and then alcohol use. Way back when, a long time ago, when I started practicing back in the late 90s, you know, we used to frequently use alcohol, use benzodiazepines to try to help people taper off their alcohol. And in some places that's still used. There's a shift in a lot of places to use non-benzodiazepine treatment for acute alcohol intoxication or detoxification in terms of using other medications such as, I'm not going to go into all those because I don't have all the evidence for all of them, but that there is a movement in multiple places to use non-benzodiazepine drugs for the treatment of alcohol detoxification. So their conclusion was that the patients who are the most at risk for adverse events were the most likely to be prescribed the medications. So it sounds a little bit intuitive, but it was interesting to see it on paper. Here we are up to 700, so we're getting there. It's about 12:30, and here we are at 700. This is like a gimme, right? Combining these two drug classes increases the risk of death by 4 to 10-fold. And I'll give you a hint. It's the name of this lecture. So everyone's got this, right? $700 for free. Too bad it's just paper money, but isn't it all? So we're going to look at a study of co-prescribing opioids and benzodiazepines. And a couple of other studies first. We found in the same time period as the opioid crisis from roughly 1999 to the past 20 years, that the rates of patients who got co-prescribed in this one study had doubled. So there were twice as many people who were taking both. And these people were also at risk of higher utilization. So we also know that related to overdose in 2011, which was the last I could find, about 30% of nationally overdoses also involve benzodiazepines. Most overdoses involve more than one substance. And in terms of opioids and benzodiazepines, about 30% nationally back in 2011. The latest data I could find in Maine was about 2017, and that was about 18% or 20% in Maine, so a little bit less than the numbers we saw nationally a few years before. So the problem with this is it's all new math, right? 1 + 1 = 10. So we add a benzodiazepine, we add an opioid, and we get exponentially increased respiratory depression. And that's the problem also with the other substances that are associated with overdose, one of which will be the final Jeopardy question, so I won't name them all. So different studies have found different increased risk, largely a 4-fold risk. When you take a patient who's already on an opioid and you add a benzodiazepine, you increase their risk of dying 4 to 10-fold. We know that people already on chronic opioids are already at higher risk of dying. So you're taking person not prescribed either, person prescribed opioid, person prescribed both. So this was one of the big studies that I'd like to look at. So this was done in North Carolina. It was a cohort study. They looked at 2.2 million patients on opioids who happened to be all of their state Medicaid patients taking opioids. And I think about that and it kind of blows my mind. I did residency and I lived in North Carolina for a while. It's a lot bigger than Maine. So they had 2.2 Medicaid patients on chronic opioids. And in the state of Maine, we only have 1.3 million people altogether. But they had a lot of patients to look at. Interestingly, in this study, again, published in 2016, 80% of their patients were co-prescribed. So 80% were taking both and only 20% were taking opioids only. They saw an increase in mortality rates similar to multiple other studies, increase in mortality rates gradually across the range of MMEs. So as your MMEs go up, especially when you're co-prescribed, your mortality rate's going to go up. And interestingly, a friend of mine recently attended a lecture, and also I attended an industry-sponsored lecture for the point of proctoring the lecture. And it was interesting because they were highlighting some studies showing they were trying to say that underlying psychiatric disease was more important in a risk of overdose than the actual MMEs. And they were trying to show us some data from these studies. And I thought that their reasoning fell a little bit short because multiple studies have shown a clear association, increased MMEs, increased mortality. And of course, if you have underlying psychiatric disease, that's going to put you at even higher risk. This was the study that found the 10-fold higher rate of mortality in terms of overdose death. So in 2016, the FDA put out this black box warning that when you combine opioids and benzodiazepines, it can result in serious side effects, including death. And so now here's the chance to put in a little bit of caveat. As you will notice in the American Family Physician, which if you're a family physician, you get this, or if you know a family physician, you can get access to it. The edition from October 1st has a great article about current thinking about treatment for opioid use disorder. And so I want to just read right from this article because I think it's really important. Previously, the US FDA warned against prescribing buprenorphine, Suboxone, to patients who used benzodiazepines or alcohol because of the elevated risk of overdose. This warning was recently removed because failing to treat opioid use disorder, even in the setting of alcohol and benzodiazepine, is riskier than treating them. So the point here being is what we were told 3 years ago was if a patient comes in and they screen positive on the urine drug screen for benzos, that we should not be prescribing them buprenorphine. That has changed. Now we know that that patient is more likely to die because we withhold their buprenorphine than by co-prescribing it. So that's not to say that if a patient is misusing or using appropriately prescribed benzodiazepines, that we shouldn't try to get them off the drug, to work with their providers, with their counselors, and work on decreasing their dose, decreasing their risk, and getting them off the benzodiazepine. So it's not to say that we shouldn't be doing that, but we shouldn't be withholding treatment of a life-saving medication just because they come into the office and they screen positive for benzo. So it's an interesting change in the way we think about doing addiction treatment. But we're still working to get those patients off the benzodiazepine slowly, right? Because if they already have an opioid use disorder, their chance of developing a benzodiazepine use disorder is 12 times higher than the average person. So we need to be doing both, but not withholding something that could potentially save their life. Here we are up to 800. This third medication should always be prescribed for patients who are currently taking opioids and benzodiazepines, including Suboxone, with or without benzodiazepines. So this one should be pretty easy. Generic name preferred. And so you'll see at the bottom of this slide, there's your answer. Naloxone, otherwise known by the brand name of Narcan. So the idea here is, in terms of co-prescribing, the #1 way to decrease the prevalence of this is don't do it. Don't do it in the first place. If someone's on one, don't give them the other. Now you run into situations where a little difficult. Maybe someone is on a chronic benzodiazepine already. They have a very serious acute injury that might need opioids for a very short term, like 3 days, right? Because we know that for acute pain, 3 days is the recommended length of treatment, like a fracture or a severe, big surgery. So then we have to be really careful, and we have to do the best we can for risk reduction. Taper doses of both opioids and benzodiazepines don't escalate. So if the treatment's not working at the dose they're on, it's probably not going to work at higher and higher doses, both for opioids and benzodiazepines. For patients who are on these drugs already, they need to be closely and frequently monitored. We need to be really careful in terms of our expectations at the beginning when people are prescribed medications. I had an interesting conversation with a provider recently, and we talked about some of the indications for using benzodiazepines. This provider was thinking that benzodiazepines are indicated as first-line treatment for multiple anxiety disorders and things like acute grief reaction. I've had a couple of providers talk to me about that. Some of that thinking, I think, has changed over the past couple of years, and we know that for acute grief reaction, actually benzodiazepines can make the outcome worse, and we need to think about some alternative treatments. We need to make sure that patients' families and caregivers know that they're at risk and that everyone is co-prescribed naloxone. So if they're on both, they absolutely need to have naloxone. But in this one study that was referenced in 2018, less than 1% of patients who were getting both were getting the naloxone. So we have a great opportunity to increase our penetration of naloxone prescribing as prescribers. It's low-hanging fruit, it's an easy ask, and it initiates a really good conversation with the patient. You are taking a medication or a combination of medications that is so risky and has the potential of killing you that we need to give you an antidote, and you should have it and your family should know how to use it. Even patients who take the medications as prescribed have inadvertent overdoses. So here's from the Surgeon General. It's kind of like the same message I keep saying over and over again. And here we are to 900. This is how often prescribers should have a face-to-face visit with any patient who receives a controlled substance prescription. This is not in the opioid law. It's not in the Chapter 21 board rules. It's a guideline or a best practice. So any controlled substance, how often should you have a face-to-face? And I'll tell you, it's not once every 2 years. And we'll talk about the 2 levels of monitoring. Can you do me a favor? Give me my bag. I have another demonstration. So they kindly handed me my bag. I got to make sure that my show and tell here is going to work. Darn it, I took it out. So I've started in the past couple of months carrying naloxone. I was very kindly provided a prescription for naloxone from Penobscot Community Health. And I have my naloxone in my bag. And I took it and put it in my backpack when I went to Boston last week. And so it's not in my briefcase here in Maine. But I try to carry my naloxone with me all the time. I was challenged by another healthcare provider. So back to controlled substance monitoring. It's on the slide after this. So we're going to talk a little bit about universal precautions, touch on tapering, and get to questions. So we want to be sure that we're doing informed consent, treatment agreements. In the Bangor area, we made a uniform document for everyone. We want to be really explicit about length of treatment so it doesn't just go on and on and on. And then just don't start putting the 2 together because it is so dangerous. In the handout, there is a copy of our Bangor area informed consent for benzodiazepines, and it talks very explicitly about the risks of using benzodiazepines. And it talks about, my provider and I have discussed the fact that these are not first-line medications and they are not the #1 recommendation, and we have chosen to proceed with this prescription regardless. It kind of says that right in the informed consent. So Benzodiazepines, there's not a law that says you have to do this, but you should do this, right? So it's like any other controlled substance, benzodiazepines, stimulants, opioids, maybe not testosterone, but especially the big three, you should have a face-to-face visit with that patient every 90 days because these are such risky medications every 90 days. Now, if a patient is on a super high dose opioids over 100, then the recommendation is every month face-to-face. Because if your patient is on over 100 MMEs, their risk of dying is extremely high. And you need to be monitoring them carefully and showing your due diligence that while they're being prescribed a potentially harmful medication, that they are being very closely monitored by you. We want to be doing PMP checks. That is the law. If you're going to prescribe a benzodiazepine, you have to check the PMP to make sure that they're not already on an opioid that you don't know about. Urine drug screens are recommended. Pill counts are recommended. And then be monitoring and be documenting very carefully. If people are on benzodiazepines for more than 2 weeks, then we need to think about tapering, kind of like prednisone. So here's 1,000. What is one possible symptom or the most widely recognized symptom of an abrupt benzodiazepine withdrawal? And there you go. There are the symptoms of, most people put seizure because that's the one that you can think about. So we have to remember that when you withdraw from opioids, it's very uncomfortable. People don't, we would like to avoid having our patients withdraw from opioids, but it doesn't kill you. It's very uncomfortable. You feel very sick and you want to avoid that at all costs, but you don't die. When you withdraw from benzodiazepines or alcohol, it is potentially fatal. So which one to taper first? Sometimes it's easier to get the opioid down quickly. Sometimes benzos take a little bit longer. And the CDC has some guidelines about tapering, all of which are a little bit aggressive. And now we know in 2019, the CDC has come out and said we need to slow down our tapering for patients. Lots of things that we can say in the right way. I'm worried about you. This concerns me. I'm going to work with you. And the idea of firing patients because they take dangerous medications or not using them appropriately is really sort of an idea that has gone by the wayside. That it is now our obligation to work with patients to get them on safer medication regimens. So we need to make sure that people are in psychotherapy when we're tapering either one of these medications, be making sure that they're taking adjuvant medications like specific antidepressants, non-benzodiazepine anxiety medications, and working with our village and our medical neighborhood to make these things happen. Patients are panicked by the idea of their benzodiazepines and their opioids of being tapered, discontinued. I think a term currently being used is de-prescribing. We're going to start with your de-prescribing because I guess that has a better connotation than tapering. So we need to be careful. You can go quickly at the beginning and slower later on. And once you've decided that it's medically appropriate that this patient's medication dose be decreased, don't go back up. Because if it's medically appropriate and it's safer for the patient, then turning around and just going backwards is not medically appropriate and it's not safer for the patient. And then generally, this is what the CDC says, way too fast for benzodiazepines. There's ways to calculate equivalent doses of benzodiazepines, and especially if someone's on alprazolam, which is a very short-acting benzodiazepine, sometimes we want to get them converted to a longer-acting benzodiazepine as we're de-prescribing to them. So there are ways to do this conversion. This kind of shows up now on the PMP, the LME, I think it says, instead of the MME, morphine milligram equivalents, the lorazepam milligram equivalents. So that data is there on the PMP. This lady in Great Britain has done a lot of research on benzodiazepine tapers, and at her website, her name is Heather Ashton, PhD, and she has a lot of different protocols that kind of walks you through how to taper people who are on higher doses or over a long period of time. Here's the final Jeopardy. The category is prescription drug combinations and overdose. I said that. So add up your score and then decide what's your wager. Are you going to bet it all? It's only paper money. Give you 5 seconds to add up your score. All right, here we go. Final Jeopardy. This prescription drug was found in 33% of the overdose patients lethal, fatal overdose patients in the state of Kentucky in 2016. It's not a benzodiazepine. It's not an opioid. What other prescription drug was found in a third of fatal overdoses in Kentucky a couple years ago? So I'll give you 5 seconds to think of that. Sometimes people say alcohol, and I'm like, yes, it's not a prescription drug, right? So we're going to just talk really quickly before we go into questions about non-benzodiazepine sedative hypnotics. So here we go, gabapentin. There's your answer. So in Kentucky, they added gabapentin to their PMP because it's a Schedule 5. Now you will probably know that pregabalin, gabapentin's cousin, known as Lyrica, gabapentin known as Neurontin, pregabalin's already on the PMP, but gabapentin is not. So we need to be really careful when we're thinking about gabapentin. We've used it a lot. There's some good evidence, which is off-label, to show that it is helpful for some patients with chronic pain with a pretty good number needed to treat. So this is an off-label use. In some cases, it's recommended as a safer alternative for opioids, depending on the patient. We have to be careful if people are taking it with opioids. I'm going to go through these quickly because we're at the end. Interestingly, they had a 50% increase in sales over the 2000 teens. So I think we're really searching for alternatives to opioids and trying to help our patients with chronic pain, and that's part of what's driven their sales, but also they have been dinged like many other pharmaceutical companies for off-label marketing, which, like I said, this is off-label. It can be easily misused. There are some positive effects if you misuse gabapentin and if you combine it with other substances. So it has a significant street value and is known. And here's the Holy Trinity. If you look at your PMP prescriber report, on the bottom left, it talks about if you have written any benzodiazepine or opioid prescriptions for someone who was receiving the other. On the bottom right, it talks about if you have any patients who have received the Holy Trinity, which is opioids, benzodiazepines, and carisoprodol. In my opinion, carisoprodol has no role to be prescribed anymore. It's a very unsafe combination in terms of respiratory depression, and carisoprodol is highly misused like many of these other drugs. So add up your Jeopardy numbers. If anyone has over 8,000, you can put it in the chat box and get bragging rights. So here we are at the end. Oh, I wanna mention that Qualidigm, formerly known as Quality Counts, has a lot of online modules that go through different opioid topics, 12 of them maybe now, online. And there's a course specifically about benzodiazepines on the Caring for Me Learning Lab online, and it has a little bit different content. It has a lot from Trip Gardner. And so I think you could watch that and you could learn a bunch of stuff in addition to what we just talked about today. It's a great module. So here we are. Benzos are not safe or effective for long-term use. We didn't talk a lot about that, but there's really no good evidence to show that they are first-line recommendations. We're increasing our patients' risk of dying when we're using them with opioids. These other drugs like C drugs, gabapentin, carisoprodol, they can increase the risk as well. We need to be working really closely with our behavioral health colleagues and working on decreasing, deprescribing these medications to patients. And last but not least, first but not least, is making sure that anyone who is at risk of an accidental overdose or an adverse reaction to their prescribed medications are being prescribed naloxone. So here are all of our references, all the different studies that I mentioned today. There's a bunch of additional slides that you'll get in this slide deck because there was so much about benzos we couldn't even fit it in an hour. And then we're gonna take questions for like the last 5-7 minutes here.
All right, so we've had a few questions come in through chat and Q&A. So I'm gonna see if I can pull all the ones out in chat. It's a little bit harder to follow, but we had one participant that was asking about a session you had mentioned. Hold on, at Brewer. I'm not sure exactly what Billy was referring to on that.
Tomorrow night in Brewer at 4:30 at Just Catering, we will have a 3-hour program on opioids. This lecture is the last of the 3 hours, but the first 2 hours will be different content than today. And you can just walk in.
Perfect. And the question was, Is there a call-in option for that meeting, or is it in person only?
These are all live. So tonight in Auburn, tomorrow night in Brewer, Thursday night in Belfast.
Okay, all right, we got that one answered for Billy, so I'm glad. I was kind of lost on that one. I was like, I don't think Qualidigm's got anything to do with that one, but
we are partnering with AdCare because we like partnerships and collaboration.
We have another question from Leslie. We are starting to see Kratom, kratom in patients. Any comments about this drug appearing and the impact known to date?
I do not know about this drug, so I'm not going to comment a whole lot. It is a drug that I believe you can get on the internet, and I know it's misused, and I suspect there's an increased risk of respiratory depression, but I have not researched that yet. Waiting for the marijuana questions because I've done some marijuana research.
All right, we have another question that came in Q&A. In the current age of increasing usage of legalized hemp products, what is the experience with using CBD in terms of helping decrease the use of opioids and benzodiazepines in treatment of anxiety and chronic pain?
So here we go. Here's our question. So hemp products, CBD, I think that they're determined by law to contain less than a certain percentage, which is like 2 or 3% of THC. So considered to have negligible amounts of THC, the psychoactive component of marijuana. So that's the CBD oil and the hemp products, whereas marijuana products would have a higher concentration of THC. So the first thing to know about marijuana products is it doesn't cause respiratory depression. That's used widely in their marketing, that essentially marijuana does not kill you and you cannot overdose on it. And that's a very, oh, our audio cut out.